Okay, the last chapter that we'll be covering before the final exam will be chapter 13, antidepressants. And so it's important to start off by talking about the nature of depression, of course, since antidepressants are primarily, although not exclusively, used to treat depression. So the first thing we should look at is the DSM-4 criteria for what major depression is. Major depression is characterized by major depressive episodes, which include various criteria such as depressed mood for most of the day, nearly every day, marked diminished interest in pleasure or in all or almost all activities. It's important to have at least one of these first two in order to meet the diagnostic criteria for a major depressive episode. And then there are some others, such as either insomnia or hypersomnia, psychomotor agitation or retardation, fatigue or loss of energy, feelings of worthlessness, etc. So anhedonia, that really gets at the idea of loss of pleasure in things. So we've talked about the concept of hedonism in the use of drugs just generally. So anhedonia is the lack of the experience of pleasure. And in addition to major depressive disorder, we also have a diagnostic category called dysthymic disorder, which is more of a low-grade depression where you may not have the symptoms in as high a magnitude, but or they may not be as severe, but they tend to be prolonged. In fact, you have to have these symptoms for at least 2 years before you meet criteria for dysthymic disorder. And in terms of the explanation of depression as a mood disorder, there's the predominant theory is the monoamine theory, which states that there are essentially three systems. Remember that monoamines cover both dopamine, serotonin, and norepinephrine. So these brain systems are believed to be primarily involved in the development of depression, at least from a neurochemical basis. So we've got norepinephrine fibers that originate in the locus ceruleus in the pons. We've got serotonergic fibers that originate from the Raphe system in the medulla, and we've got dopaminergic neurons that project from the ventral tegmental area to various places throughout the brain, which we've talked about before: the mesocortical system, the mesolimbic system, and the nigrostriatal system. So, as I said, the monoamine theory covers these three neurochemical systems, and the predominant theory is that there's decreased activity in the serotonin system. That seems to be one of the more important out of these three systems that's involved in depression. And specifically, there seems to be a problem with the serotonin transporter proteins. For instance, there's a gene located on chromosome 17 that's involved in the development of the serotonin transporter proteins, and this gene comes in two forms, a long and a short form, and there's evidence to suggest that having the short form actually puts an individual at a greater risk for developing depression, whereas having the long form of this gene is associated with sort of a protective mechanism against the development of depression. There's also evidence that the binding potential of specifically the 5-HT1A receptor subtype might also be dysfunctional in the development of depression. So PET studies have shown that there's decreased binding in individuals who have depression in this 5-HT1A area, which could either indicate that serotonin doesn't bind there as well, or alternatively it could indicate that there are just fewer receptors there for serotonin to bind to. In addition to the monoamine theory, there's also the glucocorticoid theory of depression, which states that chronic stress is involved in the activation of the HPA axis, which causes it to become overactive. So the HPA axis refers to, in this diagram here, the activation of the hypothalamus from a stressor, which causes the release of CRH, corticotropin releasing hormone. And CRH causes the pituitary gland, located at the base of the brain, to release adrenocorticotrophic hormone. And this travels through the bloodstream and connects to the adrenal cortex located behind the kidneys. And it's the adrenal cortex that then releases cortisol, which is, the major stress hormone that becomes activated in our bodies. Now, cortisol gets released into the bloodstream, and you can see that it goes back to the hypothalamus to further influence the release of corticotropin-releasing hormone, but it also goes to areas located within the limbic system, such as the hippocampus, amygdala, and the prefrontal cortex. Now, you can see that there are both solid and dashed lines here, and that the dotted lines are indicative of inhibitory mechanisms, and the solid lines are indicative of excitatory mechanisms. So you've got both excitation and inhibition. Now, normally, in the short term, we want this stress response to be relatively quick acting, and then we want to shut it off when we're no longer under the stressor. But under conditions of prolonged stress, you've got this hyperactivation of the system, and it causes these it causes this continuous activation of the circuitry. And we know that cortisol seems to have an adverse impact on the hippocampus, but it also has an effect on the amygdala. So we see differences in depressed and non-depressed individuals in terms of both the amygdala and the hippocampus. In the hippocampus, there's atrophy or loss of neurons, whereas in the amygdala, there seems to be increased size of the amygdala. So that sort of suggests that they're more responsive to stress under these conditions of prolonged stress. Now, although we have these listed as being separate theories here, it's not to say that they're independent of one another, that the glucocorticoid theory, the stress response that we experience, is directly tied in with levels of monoamines in the brain, such that under conditions of high stressors, in the long term, when we have the chronic activation of the HPA axis, there's a reduction in both the number and function of these 5-HT1A receptors in the hippocampus. And there's also evidence to indicate that in individuals who are most responsive to drugs that manipulate these monoamine systems, they're most effective in individuals who get their HPA axis regulated again. In other words, there's an improvement in HPA reactivity that corresponds with the beneficial effects of treatment with antidepressants that directly manipulate these monoamine levels, specifically serotonin. Now, the first antidepressants that were developed were what are called MAOIs, monoamine oxidase inhibitors. So again, monoamines referring to the dopamine, serotonin, and norepinephrine. These were introduced in the late 1950s, and if I'm pronouncing this correctly, iproniazid was the first drug that was founded and the first one that was marketed as a treatment for depression. It was first used as a treatment for tuberculosis, and it was sort of accidentally discovered that it also had this side effect of acting as an antidepressant as well. The second form of drugs or class of drugs that were developed as antidepressants are called tricyclic antidepressants. These were developed in the late 1950s, and the first drug that was developed, once again, not developed for depression, but developed to treat the symptoms of schizophrenia, imipramine. And tricyclic antidepressants, they also had somewhat of a different mechanism of action. And they also had a different side effect profile. They were thought to be somewhat less dangerous at first than the MAOIs. The third class of drugs that was developed, and these are often referred to as second-generation antidepressants, whereas the monoamine oxidase inhibitors and the tricyclics were classified together because they were developed around a similar time. The first SSRI that was developed, you're probably familiar with this drug, Prozac or fluoxetine. This was introduced in 1987. So the MAOIs, they work, as the name would imply, by inhibiting MAO. So MAO, monoamine oxidase, is an enzyme that breaks down levels of monoamine within the cell. And so if you break down these monoamines inside the cell, they obviously are not going to get released and plug into postsynaptic receptor sites because they've been broken down by this enzyme here. And so what MAOIs do is they increase levels of all MAOIs, all monoamines, that is dopamine, norepinephrine, and serotonin. So they're essentially monoamine agonists because they block this breakdown through monoamine oxidase. Tricyclics, they have, as I mentioned a minute ago, a different mechanism of action. They prevent the reabsorption of monoamines and act actually somewhat similar to the SSRIs and SNRIs in the sense that they're blocking the reuptake process. So the tricyclic antidepressants, they really get their name from the chemical structure, the three-ring structure of the drugs themselves. That's what really gives them the name. So they're classified as first generation along with the MAOIs, but they actually have more similar mechanisms of action to the SSRIs and the SNRIs. So the SSRIs, selective serotonin reuptake inhibitors, and the SNRIs, serotonin and norepinephrine reuptake inhibitors, or sometimes just selective norepinephrine reuptake inhibitors. They block the ability of presynaptic serotonin cells to reabsorb serotonin, or they might also block the reuptake of, in addition to serotonin, norepinephrine, and even possibly dopamine as well. So in this table here, table 13.2 from the textbook, it's 12 o'clock obviously, we can see that there are some third generation antidepressants listed here, their generic name, their trade name, and their mechanism of action. So we can see that most of these involve either a blocking of the reuptake of either norepinephrine, serotonin, or both. So if we take this first one here, venlafaxine, the mechanism of action for this drug is to block both serotonin and norepinephrine reuptake, but at high doses it also blocks reuptake of dopamine, as we can see here. So the second one, Prestige here, this one is actually the major metabolite of venlafaxine, so it also is a 5-HT and norepinephrine reuptake blocker. And then duloxetine is a 5-HT, norepinephrine, and dopamine reuptake blocker. So you can see that the reason that these are third generation antidepressants is because they're doing more than what the second generation, which are again specific to serotonin. We see that dopamine and norepinephrine and serotonin are all being blocked by these atypical or third generation antidepressants. Both the MAOIs, the tricyclics, and the SSRIs, they have similar absorption pharmacokinetics, but the absorption of SSRIs is slower than the tricyclic antidepressants. They also have high levels of protein binding, and there are some interactions with alcohol, although the tricyclics have more severe reactions with alcohol than the SSRIs, which tend to have relatively little interaction with alcohol. And so what that means is that essentially SSRIs are a bit more safe when consuming alcohol than the tricyclics are. And once again, what we're going to find out in a little while is that these drugs are all relatively equal in terms of their effectiveness, but they have very different side effect profiles and different interactions with other types of drugs, or in the case of MAOIs, interactions with different types of foods. These antidepressants, they all cross the blood-brain barrier and placental barriers. Obviously, they need to cross the blood-brain barrier easily in order to have their antidepressant effect. But in terms of passing the placental barrier, that raises the consideration for the effects on the fetus. These antidepressants, they tend to get concentrated in areas like the lungs, kidneys, liver, and brain, and they have been found in breast milk, although there's some indication that that doesn't necessarily translate into being found in the blood of newborns, because those drugs do get broken down by and metabolized by the infants themselves as well. The antidepressants vary as a function of their half-life. MAOIs have a half-lives of about 2 to 4 hours, whereas tricyclics tend to have much longer half-lives, about 24 hours, and may not reach a steady state in some people until about 5 days. The SSRIs, on the other hand, they tend to be somewhere in the middle. Somewhere around 15 to 20 hours is their half-life. Although there's also considerable individual variability with regard to the way that individual people process and metabolize antidepressants. In terms of the effects of antidepressants on the body, we do see anticholinergic effects. These anticholinergic effects include things like dry mouth, constipation, dizziness, irregular heartbeat, blurred vision, ringing in the ears, and also retention of urine. In some cases, you can also get what's referred to as serotonin syndrome, which involves symptoms of disorientation, agitation, confusion, fever, shivering, and diarrhea. Extrapyramidal symptoms are relatively rare in the use of antidepressants, and washout time is also a consideration. That has to do with the amount of time that you wait in between stopping one SSRI and starting another, stopping an antidepressant and starting another one. You want to make sure that it's completely out of the system before you start another antidepressant, because if you have two in the system at the same time, you're going to get a higher level of serotonin and other monoamine buildup, and that's what leads to the possibility of having this serotonin syndrome. The side effects of the SSRIs, they tend to be more mild. Again, that's one of the major reasons why they're preferred over both the MAOIs and the tricyclics. Their side effects can include things like nausea, headache, nervousness, and insomnia. With the MAOIs, you tend to get side effects such as weight gain, dizziness, and potentially severe adverse interactions with other drugs and food. In particular, if you are taking MAOIs and eat certain types of aged cheeses, pickled herring, drink beer, wine, or eat chocolate, there's a possibility that you could get a buildup of tyramine in your system, and that could be potentially very serious, because normally MAO breaks down tyramine, so taking an MAOI, it prevents the breakdown of tyramine located throughout the body, because MAO is not just present in the brain, it's also present elsewhere throughout the body as well. In terms of the effects of antidepressants on sleep, tricyclics are sometimes used to help with sleep. They do have a side effect of causing sleepiness, but antidepressants can also sometimes cause nightmares, and some may even increase or alternatively decrease REM sleep. The increase in REM sleep sometimes translates into more vivid REM sleep, which can be bothersome to some people. It makes your dreams seem like they're more real. The decrease in REM sleep, on the other hand, is interesting, because that might actually be related to the antidepressant effect, because there's some research that indicates that with disruption of REM sleep, not total sleep overall, but disruption of REM sleep in particular, that actually has been shown to have an antidepressant effect in and of itself. Overall, the antidepressants, they appear to be effective at the treatment of depression. It seems as if somewhere between 60% and 70% of individuals with major depression do experience relief from antidepressant medications. However, that's not taking into consideration the percentage of that improvement that might be due to the placebo effect. In fact, placebo response rates are often 30% at least and sometimes they're even higher than that. And then the other interesting thing about the placebo effect is that this effect has been getting stronger over the years. In other words, in 1980, the placebo effect was closer to about 20 to 25%. Today, currently, it's closer to about 30%. So, and we've talked about the placebo effect extensively at the beginning of this course. We know that there are different ways to manipulate how effective the placebo response can be by manipulating whether individuals are aware of are what individuals are told about whether they're getting the placebo or not. In terms of the subjective effects, antidepressants often result in people experiencing feelings of tiredness, apathy, and sometimes weakness. With high doses, there can be impaired comprehension and confusion, and nausea is another common side effect. The tricyclics have been shown to have detrimental effects on vigilance tasks and can cause cognitive, memory, and psychomotor impairment as well. The SSRIs, although not specifically labeled for use as ways of manipulating personality, there was a famous book that was written on the use of Prozac in particular in influencing people's personalities. But this was in terms of regular personalities. SSRIs may show some efficacy in the treatment of personality disorders. When we look at the behavior of the effects of antidepressants on non-humans, we see that tricyclic antidepressants are more effective than things such as methamphetamine in increasing operant response rates. They tend to decrease avoidance behavior, which is similar to what we talked about with the anxiolytics, but they do not increase punishment-suppressed behavior, which is not the same as what we saw with the anxiolytics. In terms of the discriminative stimulus properties, neither the MAOIs nor the tricyclics are discriminable at doses that produce most of their behavioral effects. So, in other words, there doesn't seem to be too much of a subjective effect of taking these drugs. SSRIs and norepinephrine reuptake inhibitors, they do have discriminate stimulus properties at therapeutic doses. So there's some discrepancy here between the MAOIs and tricyclics and what we see with the newer second and third generation drugs. It's not entirely clear whether tolerance to the effects of antidepressants develops, but there does, well, in terms of the antidepressant effects, but there does seem to be some tolerance to the side effects. Particularly, there is tolerance that develops to the tiredness of some antidepressant drugs, but for SSRIs, there doesn't appear to be a strong development of tolerance to the tiredness effects of SSRIs. When antidepressants are stopped relatively quickly, particularly with the tricyclics, you tend to see withdrawal symptoms of things like restlessness, anxiety, chills, muscle aches, and akathisia. And this tends to again be more significant when there's sudden discontinuation. With the SNRIs, those actually tend to have some of the more severe withdrawal symptoms. You can get things like heart palpitations, nausea, and delusions. With the SSRIs, again, sudden discontinuation can result in things like dizziness, lightheadedness, insomnia, fatigue, anxiety, nausea, headache, and sensory disturbances, and these may last up to 3 weeks. These drugs do not appear to be reinforcing in either humans or non-humans. Neither tricyclics nor MAOIs tend to be abused. SSRIs don't tend to be abused by individuals either. Some SSRIs are used to treat addiction to other drugs. So, for instance, alcohol and smoking are sometimes treated with SSRIs. And in fact, rather than being abused, there seems to be more of a problem with compliance. That is, in order for antidepressants to be effective, they need to be taken according to a regular schedule. And because the SSRIs tend to have the lowest side effect profiles associated with them, they tend to have the best compliance rates. But with the tricyclics and the MAOIs, because of certain restrictions with diet with the MAOIs, and because of the relatively lower therapeutic index of tricyclics, those tend to not be preferred, and they also tend to have more side effects. In terms of the harmful effects of antidepressants, for the tricyclics and for the antidepressants more generally, there do appear to be a number of sexual side effects, in particular for males. There are reports of dysfunction for males, and for MAOIs, there are reports, or it's actually relatively well known that there's both a decrease in libido and an effect of delayed ejaculation in males. In terms of antidepressants' effect on pregnant or nursing mothers, there's some evidence to suggest that the rate of miscarriage may be somewhat higher, although it's not clear whether that was a direct result of the effects of drugs or something else, particularly when you're doing these studies in humans. In terms of violence and suicide, there's a warning label on SSRIs now. In particular, this label this black box warning, which is a serious warning that's placed on medications, applies to young adults up to the age of 24. Just because there have been in clinical trials higher rates of suicide among individuals taking the SSRIs in comparison to those taking the placebo. Now, once again, these are individuals who are experiencing major depressive episodes. Major depression is a major risk factor for suicide, so it's not clear whether it's the antidepressants that are increasing the risk of suicide, or whether potentially these are people that are just not responding as well to the effects. Other harmful effects include the serotonin syndrome that we mentioned earlier. That's most likely to occur when antidepressants are used in conjunction with other drugs that increase monoamine levels, for instance, psychomotor stimulants. The tricyclics, again, they tend to have a lower therapeutic index relative to the SSRIs, and some MAOIs have also been linked to high death rates. The SNRIs and SSRIs are considerably safer, and there have been no overdose deaths that have been attributed to the use of fluoxetine. In terms of other treatments for depression, electroconvulsive therapy is more of a last resort type of antidepressant treatment, although it has been shown to be very effective in those that don't respond to the traditional antidepressant drugs. Deep brain stimulation is another last resort sort of treatment, and transcranial magnetic stimulation is a very new antidepressant treatment strategy. There are very few harmful effects, as well as people are properly screened for the use of this, and the first clinical trials are now just starting to come out, and it's shown a couple promising effects in a couple of studies with relatively small sample sizes, so we still have to see what turns out as more and more studies are done with TMS.